My name is Jay Humphrey. It's a pleasure to welcome you to this webinar. And as we start, I'd just like to share two slides. The first is a slide that I put together for a GenTAC meeting a number of years ago, where I reviewed a few papers that were published in the literature on thoracic aortic aneurysms and dissections. You see the papers cited below. And I did a word study and created this word cloud. And the size of each word indicates the frequency at which that word appeared across these 5 articles. And as you can see, many words relating to biomechanical factors, including stress and strength and strain, mechanotransduction, integrin, force, etc., appeared in these reviews, suggesting that many are very well aware that biomechanical factors drive thoracic aortopathy. And today it's really my pleasure to introduce to you 2 individuals who will speak to us, Dr. Jonathan Weinsaft from New York Presbyterian and Cornell Medical Center in New York. He is director of the cardiac MRI at NY Presbyterian. He's a physician scientist who will tell us about hemodynamic factors that affect thoracic aortopathy. And also Professor Chiara Bellini from the Department of Bioengineering at Northeastern University, who will tell us about the influence of biomechanical factors on the wall mechanics. So without any further ado, I will stop sharing my screen and invite Dr. Weinsaft to start us off and share your screen. Thank you, Jonathan.
Thank you very much, Jay. Thanks, Chiara, and thanks to the audience for joining us today. It truly is a pleasure to share with you some of our work in this area. So as Dr. Humphrey spoke of earlier, I'm going to be speaking on biomechanical factors driving thoracic aortopathies, with focus on imaging evidenced hemodynamics, and specifically the power of new imaging technologies to elucidate biomechanical differences in relation to etiology of thoracic aortopathies, as well as the effect of therapeutic interventions with respect to their effect on aortic biomechanics. Certainly, as a background, we all know this in terms of the audience, the importance of thoracic aortic aneurysms with regard to their long-term sequelae, specifically among their most devastating sequelae, that being aortic dissection. We know that the presence of aortic dissection for both type A as well as type B dissection strongly impairs prognosis. If we look at data from IRAD, there's a strong association with respect to mortality risk, and that mortality is certainly mitigated with prompt recognition and surgery. And we can show similar data for patients with genetic aortopathies, demonstrating an equivalent pattern. Epidemiologic data would suggest to us the incidence of downstream complications of adverse remodeling in patients with aortopathies is increasing. It's increasing on a population basis for both degenerative thoracic aortic aneurysms in the context of increasing prevalence of coronary artery disease, atherosclerosis, and hypertension driving adverse aortic remodeling, as well as a slight increase in recognition of genetic aortopathies, which also bear serious and potentially important clinical complications. Oh, am I not sharing? No. Are you not seeing my slide share?
No, Jonathan, if you can share your slides.
Hold on one sec. I should be sharing. Hold on one sec. Hold on one sec. Do we see? Are we good now?
We can see it in presenter mode.
Yep.
Perfect. Thank you, Jonathan.
Sure. Certainly, if we look at population-based data, you can see increasing recognition in terms of prevalence of both genetic as well as degenerative aortopathies. The conclusion and the important point is that therapeutic options are improving. And this certainly highlights the need for effective screening towards the goal of improved risk stratification. What we also know in terms of background is that while imaging is widely used to stratify longitudinal risk for aortic dissection with respect to aortic size. And that certainly size of the ascending thoracic aorta as well as the descending thoracic aorta is a powerful predictor of long-term outcome. If we look at this data from Yale, from Davies et al. Initially, among 304 patients, the large majority of which were non-syndromic thoracic aortic aneurysm, the risk for aortic dissection linearly increased in relation to size of the ascending aorta. We look at genetic focused analyses. This is by John Doe's group in terms of Marfan syndrome patients. Similar linear increase in terms of risk for aortic dissection in relation to aortic size in and of itself. But we also know that conventional imaging indices do not fully account for aortic hemodynamics, and that they're limited for predicting adverse remodeling and ultimately clinical events in patients with genetic thoracic aortic aneurysms. Some of the clearest demonstrations of that came from data from the GenTAC registry. Here's data from our group in collaboration with GenTAC looking at nearly 2,000 patients with genetically mediated thoracic aortic aneurysms, a quarter of whom had Marfan syndrome, 39% of whom had bicuspid aortic valve-related aortopathies. About a third of the population had undergone prior prophylactic graft surgery. And as many of the audience know, standardized imaging, core lab analysis, as well as rigorous clinical follow-up was performed for aortic events. What data from GenTAC showed was certainly that there was a far higher risk for aortic dissection among patients with Marfan syndrome as compared to bicuspid aortic valve, and that this was associated with risk even after controlling for aortic diameter, highlighting the importance of understanding underlying differences in biomechanics of the native thoracic aorta as a potential mechanism for recurrent events. When one looks at conventional imaging indices in terms of aortic size in and of itself, we can demonstrate that certainly there is a statistical difference in terms of aortic size as a predictor of dissection risk. Patients with increased aortic diameter, increased linear cross-sectional diameters, were at greater risk for aortic dissection than were those with smaller aortic dimensions. But despite larger absolute aortic size, what the data also showed us is that patients with aortic dissections rarely had pre-dissection images fulfilling conventional criteria for prophylactic surgery. Among subjects with type A aortic dissection, only 1 out of 9 had a diameter greater than 5.0. And among patients with type B dissection, again, the large majority had minimal aortic dilation, highlighting the limits of this approach. Here's a representative example demonstrating that. Both pre and post dissection imaging, we can see mild but present dilation of the descending thoracic aorta prior to dissection, as you can see on the image on the left, 3.0 centimeters, with a subsequent type B dissection. Similarly, in this patient on the right, minimal borderline dilation of the aortic arch with a subsequent dissection in that region. The question comes as to whether novel imaging technologies, both for acquisition and post-processing, can inform native aortic biomechanics and thus also its response to therapeutic interventions in patients with genetic thoracic aortic aneurysms. Now, the notion that aortic properties differ between aortic etiology, between genetic etiologies of aortopathies, has been well demonstrated in a number of studies. Here's data from our group looking at 60 patients with differing etiologies of aortopathies, 35 patients with bicuspid aortic valve, 15 Marfan patients, as well as controls, in which we analyzed aortic distensibility, namely cardiac MRI quantified distensibility, as well as wall motion excursion or strain, to calculate aortic stiffness index between patients with Marfan syndrome as well as other conditions. What you can see from this data is that bicuspid aortic valve patients were similar with regard to both controls as well as Marfan syndrome with regard to age and blood pressure, also with regard to stroke volume as well. But regarding biomechanics, Cine CMR or functional CMR demonstrated stiffness to be far greater in patients with Marfan syndrome, as shown in the bar graphs on the right, as compared to controls, and a similar sort of trend when Marfan syndrome patients were compared to those with bicuspid aortic valve. Again, this stiffness differed between groups despite similar aortic size, consistent with the notion that underlying wall stiffness, underlying vessel properties differ in relation to etiology of thoracic aortic aneurysms, and that those differences can be discerned using new functional imaging techniques. Extending on that notion, our group has looked at the concept that intrinsic differences in vessel wall stiffness can also be discerned not only at baseline, but also with regard to post-procedural changes and post-graft variability after implantation of proximal aortic grafts. In this study, we looked at 45 patients with thoracic ascending aortic aneurysms undergoing prosthetic graft implantation of the proximal aorta, meaning root or ascending aorta. Here we're analyzing routine transesophageal echocardiography, in which, like the prior cardiac MRI data, we're analyzing wall motion excursions so as to quantify strain or fractional area change of the descending thoracic aorta. When one looks at this, we can demonstrate that after grafting, descending thoracic aorta circumferential strain increased, paralleling other indices such as distensibility and fractional area change, consistent with the notion that the graft itself is altering biomechanics or energy transmission to the descending thoracic aorta. What's of interest is that in this study, pathology data demonstrated that patients with cystic medial necrosis had higher post-procedure descending aortic strain than did those with atherosclerotic aneurysms, suggesting that the response to the implantation of a stiff or non-compliant proximal graft varies based on intrinsic tissue properties of the descending thoracic aorta or native thoracic aortic tissue. We extended on this concept looking at ambulatory post-operative patients. So here we're not using cardiac MRI as we did in our first study, and we're not using transesophageal echo as we did in the second study I referenced, but we're using routine transthoracic echocardiography to ask the question as to whether the intraoperative changes that I described to you earlier in terms of our surgical patients were sustained when we look at ambulatory patients studied pre and post proximal aortic graft implantation. Again, we're analyzing these echocardiograms for wall motion of the descending thoracic aorta, and we're doing it using a feature tracking technique commonly referred to as speckle tracking, which derives strain. Transthoracic echoes were performed in median interval of 1.9 to 2.4 months pre as well as post-operatively, and analyzed as I referred to you earlier. Consistent with the data that I showed you earlier in terms of our transesophageal echo, we can demonstrate using transthoracic echo a similar sort of pattern, that there was increased distensibility, increased strain, and of interest, those changes in terms of distensibility or of excursions of the aortic wall parallel those of altered kinetics, meaning that flow kinetics actually alter, as evidenced by decreased time to achieving that peak strain, as well as increased flow velocity in the descending thoracic aorta. all consistent with the notion that a stiff graft propagates an energy propagation to the descending thoracic aorta, thus altering aortic biomechanics, and that those alterations can be discerned via new techniques. What's interesting as well is that, consistent with our transesophageal data I showed to you earlier, that magnitude of that change of strain or area was far greater in patients with genetically associated, meaning Marfan syndrome or congenital thoracic aortic aneurysms, parallel than as compared to degenerative aortic aneurysms. And that those differences may have stemmed from variability in terms of aortic geometry. We found larger descending thoracic aortic size, higher wall thickness, and higher prevalence of calcific aortic plaque in genetic aneurysms, suggesting the concept that in degenerative aneurysms, suggesting the concept that in terms of degenerative aortopathies, there is greater resistance to that graft-induced alteration in terms of flow physiology, and thus smaller decrements in terms of post-operative strain. We next asked, and other groups have asked, as to whether new imaging approaches can elucidate biomechanics underlying native aortic physiology. What I've shown to you thus far are interesting, although fairly conventional techniques in terms of both functional MRI as well as functional echocardiography. And while those techniques are certainly important in terms of demonstrating variability with regard to wall mechanics between patients with degenerative and genetic aortopathies, as well as strain and changes in distensibility after proximal aortic grafting, they're limited in terms of their ability to discern global alterations in terms of aortic biomechanics, as well as the modifying impact or potential modifying impact of small and subtle changes in flow physiology. Certainly one area and one pulse sequence of potential interest, which has proved very valuable, at least to date, in terms of discerning some of those changes, has been that of four-dimensional flow MRI. It's an area in which our group is working, as well as a number of other groups in the space. Here's an early study by Michael Markle's group at Northwestern in Chicago, looking at patients with respect to thoracic aortic aneurysms in regard to differences in flow physiology as pertains to diagnostic etiology. And one can see, as shown in this group, by this group, that flow physiology with regard to peak velocity, vorticity, and vorticity components varied between patients with bicuspid as well as tricuspid valve-related aortopathies. And subsequent studies have looked further into this and demonstrated similar findings when one stratifies patients with Marfan syndrome as compared to those with BAV. Most recently, and very interestingly, in terms of studies looking at changes or associations between four-dimensional flow evidence wall shear stress and actual aortic wall composition, is data, again, from Northwestern looking at this concept. In this study, the investigators performed 4D flow CMR in 20 patients with bicuspid valve-related aortopathies undergoing proximal graft replacement. And they used cardiac MRI or 4D flow CMR-derived wall shear stress as an index for which they were able to compare to actual histology and histopathology. Of interest, regions of increased wall shear stress, meaning high flow on four-dimensional flow CMR, showed greater medial elastin degeneration as compared to areas with normal wall shear stress, including decreased elastin and thinner fibers. When one looked in terms of molecular signaling, TGF-beta, as well as an array of matrix metalloproteinases, were increased in regions of wall shear stress elevation, consistent with the notion that what we're seeing in terms of imaging is a marker reflecting extracellular matrix dysregulation in affected areas. One focus in terms of using this approach, certainly of interest and excitement, as to whether is the question of whether new imaging approaches such as 4D flow can elucidate the biomechanical effects of aortic-directed therapies. And this is an area in which we've had great interest and a great degree of focus. In an initial study, this is again by Arturo Evangelista and collaborators, looking at four-dimensional flow CMR. This study looked at 47 patients with bicuspid aortic valve undergoing 4D flow at baseline, as well as follow-up CT for growth rate. Of interest and of pertinence, wall shear stress, as well as its circumferential component, was associated with increased ascending aortic growth rate. This is in both univariate analysis as well as in multivariate analysis, corrected for both stroke volume as well as either baseline aortic diameter or Z-score. Here you can see on the right a scatter plot showing circumferential wall shear stress in relation to growth rate. Of note, circumferential wall shear stress was associated with increased growth rate, particularly in ascending aortic regions with the fastest growth, suggesting the concept, the notion, or supporting the notion that aortic growth is a heterogeneous phenomenon, varies in terms of regions, regionality of the aorta, and that wall shear stress, as well as biomechanical factors influencing cell signaling pathways and ultimately elastin degeneration and otherwise may be driving this process. Certainly supporting the notion that new technologies such as 4D flow can discern this. With regard to therapeutic response, our group has been particularly interested in the impact of proximal grafting on downstream flow physiology, an area in which we've similarly used four-dimensional flow as an investigative tool. Now, I showed you some of our data initially looking at pre- and post-operative patients, looking at functional data. I showed you some data looking at transesophageal as well as transthoracic echocardiography, demonstrating increased vessel wall strain and distensibility after proximal graft implantation. And we noted that that magnitude of change in distensibility was greatest in genetic aortopathies. Here's data in 29 thoracic aortic aneurysm patients undergoing cardiac MRI pre- and post-operatively after graft implantation. We're doing four-dimensional flow for wall shear stress and using cine-CMR to quantify vessel wall strain in that same manner that I showed to you earlier. Of note, the two indices, both 4D flow derived wall shear stress and circumferential strain on functional CMR, correlated well, and that correlation was demonstrated throughout the thoracic aorta, similar magnitude. What we did find in terms of temporal changes is that proximal implantation of current day Dacron grafts, which were stiffer, less compliant than native aortic tissue, markedly changed flow physiology, not only within the graft, but also downstream. So here we can look at both flow velocity within the ascending aorta, meaning within the graft. We can see that velocity and wall shear stress increased, but there were also increments in the aortic arch immediately distal to the graft. And those changes were paralleled by changes in aortic distensibility as measured by cine-CMR. When we looked distal to the graft, not just in the aortic arch, but far downstream in terms of the mid-descending and thoraco-abdominal aorta, we found similar sorts of findings. Flow velocity, this is in native aortic regions, increased after graft implantation, as did wall shear stress. And those increments were paralleled by changes or increases in wall strain, as well as fractional area change or distensibility. Of note, the magnitude of change in terms of downstream aortic alterations in both vessel wall distensibility measured by strain, as well as wall shear stress measured by four-dimensional flow, varied based on etiology of these thoracic aortic aneurysms. And as shown to you earlier in terms of our echo data, we found similar patterns in terms of four-dimensional flow and cine-CMR, with magnitude of increase greatest, again, in the native descending aorta after proximal grafting. That magnitude of increase was greatest in patients with genetic aortopathies. Of note, when we compared this to normative controls, specifically focused on genetic aortopathies, we demonstrate that in terms of post-operative findings in heritable TAA patients, post-operatively, despite similar aortic caliber compared to normative controls, again, these post-operative measurements that we found were significantly greater, higher than normative age gender match control. So it's not as if the surgery, the proximal grafting, is restoring normative downstream aortic physiology. Really what we're looking at is a whole new set of native downstream physiology, a whole new parameter, whole new construct that is altered intrinsically by the proximal graft in and of itself. Last of note and of interest, two concepts to just highlight. We demonstrate in terms of this data set that both wall shear stress and circumferential strain increased after grafting, and that the magnitude of these of the decrement, of the graft-induced decrement in aortic size strongly correlated with increase in downstream circumferential strain and distensibility, meaning the greater the change in proximal aortic geometry, the greater the increase in distal, or the alteration in distal aortic biomechanics. Last, I'll just put out to you some data that's not yet published, but certainly provocative. Are the short-term effects of these grafts on downstream aortic hemodynamic sustained? Well, we don't know the answer to that, and that's certainly an area that our group, in collaboration with Dr. Humphrey and others, Dr. Alberto Wadelli, Politecnico in Milan, are actively working. But our data suggests that that is the case. Looking at retrospective data from our lab, in which we perform four-dimensional flow in 3 cohorts, Marfan patients with non-surgical aortic geometry, Marfan patients with chronic prior graft replacement, I mean, this is graft replacement on average about 7 years prior, and normative controls, we demonstrated, or our findings suggest, that when you look at four-dimensional flow physiology derived wall shear stress, the Marfan patients with surgery are different with regard to the biomechanical features in relation to those without surgery, again, matched for age, gender, and aortic dimensions, as well as controls. So here we see on the left in gray in the ascending aorta, this is within the area of graft. Obviously, the patients with grafts have higher wall shear stress within those grafts. But even distal to the graft, this is chronic. Patients in terms of the aortic arch and descending thoracic aorta in and of itself, significantly higher wall shear stress. I mean, in the post-surgical patients, this is now 7 years out, compared to Marfan patients similar age and gender without surgery, and obviously higher versus controls. So in conclusion, current imaging approaches predicated on aortic size, risk stratification for risk stratification in genetic aortopathies don't account for both aortic tissue properties as well as hemodynamics and resulting biomechanical alterations. New imaging technologies, including biomechanical characterization by cardiac MRI or echo, as well as tissue characterization by modalities such as PET, hold the potential to really improve mechanistic insights as well as prognostic insights. And finally, that emerging data suggests native aortic biomechanics to intrinsically vary based on thoracic aortic aneurysm etiology, as well as after graft replacement. Certainly, incremental prognostic data, utility of these data are unknown. So thank you very much for your time. I'm going to now turn over the floor to Chiara Bellini. Dr. Bellini?
Thank you, Jonathan.
Thank you, Dr. Weinsaft. And let me just interject that we will take questions through the Q&A tab at the bottom at the end of Dr. Bellini's presentation. Thank you, Dr. Weinsaft. And we can see your screen. Thank you.
Okay, perfect. It changed somehow from the training section. Get the annotation. All right, thank you for the introduction and for the wonderful presentation, Jonathan. I'll jump right in. So the natural history of ascending aortic thoracic disease involved the asymptomatic enlargement of the aortic root, the ascending aorta, or both, until the vessel ruptures or dissects. And both these outcomes are mechanical events that occur when the loads applied to the wall exceeds the strength of aortic tissues. It is therefore crucial to understand what renders the wall of the ascending thoracic aorta vulnerable to rupture or dissection. And perhaps a clue to answer this question comes from the genetic mutations that predispose to the disease. Indeed, this mutation often prevent the transmission of mechanical stimuli throughout the extracellular matrix, compromise the ability of medial smooth muscle cells to sense mechanical cues, or disrupt signaling in response to mechanical stimuli. So building upon this observation a few years ago, Jay, Diana, and others have suggested that thoracic aortic disease may be linked to impaired mechano-sensing and mechanoregulation of the extracellular environment, but what we think is the functional unit of the media, which is composed of the elastic fibers and the contractile smooth muscle cells. And so to link these hypotheses back to the mechanical failure of the wall, in the first part of my talk, I will discuss the effects of these impaired mechano-sensing and mechanoregulation on tissue mechanics and organ function in preclinical models of thoracic aortic disease to explore what may be the cause of wall weakening. And then in the second part of the talk, I will present data on the regional variation in wall mechanics along the aorta in patients with thoracic aortic aneurysm, touching on to potential implications for surgical intervention. So to evaluate the mechanical properties of the aortic wall, we perform biaxial tests on isolated samples, that usually in the form of inflation extension tests for mouse tissues or planar biaxial tests for human tissues. Regardless, from the experimental measures of load and geometry or local strain, we obtain two plots of stress versus either strain or stretch, one in the circumferential and one in the axial direction. And then we use these plots to estimate the parameters of a constitutive model, which allows us to predict values of stress, stiffness, and energy for each pair of axial and circumferential deformations. We're particularly interested in the elastic energy as it measured the Windkessel function, and so the ability of the aorta to deform under systolic loads and then recoil to augment diastolic blood flow. As you can appreciate, the relationship between stress and strain is highly nonlinear, and the cyclic strain the tissue experiences between diastole and systole, which fall within the gray shaded area, only account for a small portion of the overall deformation. And so we can think about the cyclic strain and small deformation that superimpose to large deformations that occur between diastole and a configuration where the aorta does not experience any load. Finally, the axial and circumferential responses are strongly coupled and synergistically contribute to the overall mechanical behavior. Because of this coupling, each strain corresponds to a different level of stress depending on the experimental loading protocols, which are color-coded here on the graphics. And in each of these protocols, we vary the ratio between the stretch applied in either of the two directions. So to the point, both circumferential and axial strains are necessary to determine each stress. And so we first applied these tools to compare a set of mouse models phenocopying a broad spectrum of human thoracic aortic disease. So the normal mouse ascending thoracic aorta is shown on the top left here. So for our purposes, we considered a segment between the aortic root and the brachiocephalic arteries that is approximately 3 millimeters long and has an outer diameter of approximately 1 millimeter when unloaded. And so we analyzed 2 mouse models of Marfan syndrome carrying pathogenic mutations of the fibrilin-1 gene. One where the disease manifests around 8 weeks of age, and the other with delayed onset of symptoms around 30 weeks of age. We then have 2 models carrying mutations in genes that code for proteins of the fibrillin family. So while the smooth muscle cell specific deletion of the fibrillin-4 genes causes mice to develop large aneurysms of the ascending aorta with tissue lesions that are visible under a dissection microscope are indicated by the white arrows there. The aorta of the fibrillin-5 knockout mice becomes elongated and tortuous, but not aneurysmal. Next, the postnatal genetic mutations that reduces the aortic expression of TGF-beta receptor type 2 causes the thoracic aorta of affected mice to thicken, dilate, and dissect, with the occasional formation of intramural hematoma and false lumen. Further, mice that carry the rare but recurrent R247C mutation on the smooth muscle myosin heavy chain gene have arteries that appear normal upon gross examination, but they develop dissection when made hypertensive. And so finally, a large dose of a potent vasoconstrictor dramatically increases blood pressure and results in a dilatation of the ascending thoracic aorta in epoe mice. We also collected data from the ascending thoracic aorta of control mice following acute in vitro intraluminal exposure of elastase. And so these arteries exhibit a very stiff collagen-driven response that reveals the effect of a complete loss of elastic or mechanically competent elastic fibers, and therefore establishes a meaningful upper bound for comparison. So using the estimated material parameter from our model, we predicted the mechanical metrics of interest at systolic pressure and preferred axial stretch. So we plotted each metric as a function of the normalized diameter, which is an index of dilatation that is expressed as the ratio between the diameter of each sample and the diameter of a control aorta that comes from a mouse of the same weight. We first noted that the increased dilatation of the ascending aorta across models correlates well with a decrease in both circumferential and axial stretches, with the aneurysmal aortas being the least deformable. Next, we found that biaxial wall stresses are either normal or reduced in all mutant and pharmacologically treated models. And this is probably due, at least in part, to increased wall thickness and the decrease in axial stretch. And so together, this finding really suggests that circumferential wall stress, not stretch, is controlled during aneurysmal enlargement. Furthermore, the elastic energy storage decreases with all mutations in treatment, and that reflects reduced mechanical functionality because recall that the key role of the aorta is to use energy stored during systole to augment diastolic blood flow. However, this reduction in energy storage does not correlate with aneurysmal enlargement because the non-aneurysm prone ascending aorta, such as the fibrillin-5 knockout mice, it also exhibit marked reduction in elastic energy. Similarly, cyclic distensibility between diastole and systole decreases in all aneurysmal models, which reveals a structural stiffening of the wall that, however, does not correlate with aneurysmal dilatation. So arguably the most insightful outcome of this study is that intrinsic stiffness of tissues in the circumferential direction increases proportionally with the degree of dilatation, reaching its highest values in enlarged hypertensive epoe mice and aneurysmal Marfan and fibulin 4 smooth muscle knockout aortas. Note that the aneurysmal vessels exhibit value of circumferential material stiffness that are very similar to those that are experienced by elastic exposed aortas, in which essentially there is no matrix remodeling. So this is very intriguing since current evidence suggests that circumferential material stiffness is a highly regulated parameter. So to convince you about that, I'm showing here a plot of intrinsic stiffness of tissues in the circumferential direction that progressively increases with age in the female wild type ascending aorta, but only significantly so between the first and the last time point. And second, carotid arteries tend to adapt mechanically in many cases of altered hemodynamics and disease by maintaining circumferential stiffness near homeostatic preferred value, which is thought to be mechanobiologically favorable. And so based on this evidence, the elevated tissue stiffness in the aneurysmal ascending aorta supports the idea that intramural cells may not be able to properly mechano-sense and mechano-regulate the matrix in the circumferential direction. And even further, it suggests that the dysfunctional mechano-sensing may lead to smooth muscle cell to interpret either a normal or high stress as a low stress environment, which thus would promote the activation of repair signaling pathways that locally weaken the wall and render it vulnerable to aortic dissection and rupture. I will now move on to the second part of my talk to discuss the regional variation in wall mechanics along the ascending aorta in patients with ascending aortic aneurysm. So although anti-hypertensive treatment may help reduce aneurysm growth, the conventional treatment of ascending aortic aneurysm or dissection remains open repair. While open surgical replacement is safe for most patients, 8 to 20% of patients with acute type A dissection are too high risk for this approach and would benefit from a less invasive procedure with thoracic endovascular repair or TEVR. So several reports have discussed the off-label application of existing commercial stent grafts for the repair of the ascending thoracic aorta in a multi-center early feasibility trial with a research investigational device is currently ongoing. And so in one of these studies, Dr. Roselli and his team at the Cleveland Clinic showed that the survival of patients who receive endovascular repair for ascending aortic disease vary depending on the affected anatomical location. Specifically, the survival was significantly worse in patients with zone 0A or aortic root pathology when compared to patients with a 0B or 0C disease in the proximal and distal region, respectively. Furthermore, in addition to old age, aortic pathology extending in the root was an independent predictor of mortality. So it seems reasonable to speculate that these outcomes may reflect unique properties of the aortic root in terms of anatomy, hemodynamics, and structural mechanics. And so to test this hypothesis, we characterized the biaxial mechanical response of tissues from the root, proximal, and distal regions of the ascending thoracic aorta in patients who underwent elective ascending aortic replacement at the Cleveland Clinics as part of the Matador study. So at this point, we have data for 80 patients. and half of them have bicuspid aortic valve, while 17 suffer from connective tissue disorder, primarily Marfan syndrome. The remaining 22 patients have no known risk factor for ascending thoracic aortic aneurysm except for older age, and we identified them with the general term of thoracic aortic disease, or TAD. To account for expected changes in mechanical properties with aging, we identified 3 age groups, with the first group including patients between 20 and 40 years old, the second between 40 and 60, and the third beyond 60. The first step of our analysis requires estimating the constitutive descriptor of the biaxial mechanical behavior for each sample. However, because the tissue response is highly nonlinear, the average of the material parameters does not describe the average behavior. Rather, we must resort to surface fitting and interpolation of the stress data in the axial strain circumferential strain plane in order to generate average data sets, which are shown here in black. So overall, the average data consists of 2 stress versus stretch curves for each group, one in the circumferential and the other in the axial direction, surrounded by shaded areas that are indicative of inter-patient variability. And so specifically in these plots that I'm showing here, average data for the aortic root are in yellow, while orange and blue display average data for the proximal and distal ascending thoracic aorta, respectively. Focused on the bicuspid aortic valve patients, in young patients, the root exhibits larger circumferential distensibility and axial extensibility compared to the other 2 regions. The yellow curve extends to the right of the other 2. Though this relationship really reverses with age. Furthermore, the biaxial response of the proximal ascending aorta does not differ from that of the distal region. Those are the orange and blue curves in the youngest and oldest patients. However, the proximal region approaches the behavior of the root in the middle age group, which has been a focus group of our analysis. So this finding probably relate to the differential effects of aging on the 3 anatomical region of the ascending aorta in the presence of bicuspid aortic valve. While this comparison provided general idea on how biaxial mechanics changes with the region, thoracic aortic disease, and age, they're mostly qualitative in nature. And so, as I mentioned at the beginning of the talk, the mechanical metrics of stress, stiffness, and energy depend both on the stretch that the tissue experiences in the axial and circumferential directions. And as a note, these stretches are defined between a configuration where the aorta is pressurized and axially extended, such as the diastolic and systolic configuration, and a configuration where all loads have been removed, which we call traction-free configuration. And this configuration, really, the tissue never experienced in vivo. And so while it is possible to evaluate cyclic strain between diastole and systole from medical images, as Jonathan showed, the global deformation that are necessary for calculating the stress and the stiffness and the energy cannot be easily measured, and therefore we need to resort to numerical models. To establish a consistent level of deformation across samples, we leveraged a characteristic behavior of aortic tissues, which support constant axial force despite pressure changes when maintained at a preferred value of axial stretch, which we define here as the crossover stretch. We then use patient-specific values of systolic pressure, thickness, and luminal diameter that are measured from images to estimate the in unloaded diameter in the traction-free configuration by solving equilibrium equation. Finally, we use the estimated unloaded diameter to predict the circumferential deformation within the desired range of pressure, from which we then calculated the mechanical metrics of interest. To validate our model, we first compare predicted diameters in the traction-free configuration with diameters measured from a few excised aortas, like the one showed here on the top right, finding that most predictions fall within 15% of the experimental values, which are the darker gray shaded area in this plot. We then showed that predicted values of circumferential stress fall within the range reported for patients with ascending aortic aneurysm for pressure between 100 and 220 millimeters of mercury, which again are the shaded area here in red, noting that the average systolic pressure for our samples fall within this range. Finally, our model was able to recapitulate cyclic strains as measured between diastole and systole in either patients with ascending aortic aneurysm, which is the red line here, or older patients, the blue line. And so using this model, we were able to compare the biaxial mechanics of the aortic root, proximal and distal aneurysmal aorta at region-specific values of preferred axial stretch and systolic pressure. The preferred axial stretch itself was lower in the root compared to the other two regions, which contributed, at least in part, to a lower energy storage at this anatomical location. Although the aortic root was also thinner than the proximal and distal ascending aorta, biaxial stresses were, for the most part, preserved across regions. Importantly, biaxial stiffness gradually decreased when moving away from the heart. Note that the intrinsic stiffness of aneurysmal tissue in patients is on the same order of magnitude of what we have measured in our preclinical models. Therefore, because circumferential material stiffness appears to predict the severity of aneurysmal disease across mouse models, the larger stiffness of tissues that it exhibited by the root may explain why aortic disease affecting this region has emerged as an independent predictor of mortality in patients that are treated with endovascular stent grafts. And now, of course, we're going to have to stratify this result by age and disease, taking a clue from what Jonathan has showed in his presentation. So with these, I conclude my talk on the biomechanics of the aneurysmal ascending thoracic aorta, which reveals some interesting parallel between mouse and human tissues. I would like to thank students and colleagues who contributed to data collection, analysis, and interpretation. This was in my group, most of the work of Samar, and the funding agencies that support this work. And I'm looking forward to the Q&A session.
Thank you very much, Dr. Bellini. If you could stop sharing your screen, and if Dr. Weinsaft could turn on his video. Again, if you have a question, please use the question and answer the Q&A tab at the bottom. And I would also like to congratulate both of you on wonderful presentations. Thank you so very much. There is one question already in the Q&A box. You can see it yourselves. It's from Lee, who says, amazing work. Ascending aorta replacement could increase wall strain of the native arch and descending aorta. Do you know the effect of replacing both ascending and descending aorta on the strain of the native arch? And either Dr. Weinsaft or Dr. Bellini, please feel free to address the question.
We do not have data for patients that have that from a biomechanics ex vivo in vitro biomechanics perspective. So I'm not able to comment on that.
So that's a great question, and an increasingly pertinent clinical question, not in terms of surgical replacement of the descending thoracic aorta, but often in terms of increasing use of stent materials in the descending thoracic aorta, which is certainly a growing area of interest. We don't have direct data on that, but what we do have data on, which I think gets at that question, is emerging data looking at the effects of proximal grafting on diastolic physiology of the left ventricle. Again, is supporting the notion that prosthetic grafting using current day grafts markedly will alter afterload, seen by the left ventricle in this example, and in the construct that the questioner presents, as would be seen by the aortic card. So certainly that's an that's an interesting area of research. We hope to have data on that as we expand these areas of study in collaboration with doctors Girardi, Gaudino, Lau, and our cardiothoracic surgery colleagues here at Cornell, who are working closely with us, and certainly an important area of research.
Thank you, Dr. Weinsaft. There's one more question, and given the time, I'd like to address that. It's from Dr. Sanjay Sinha from the UK. Thank you, Sanjay, for joining. Questions for Dr. Bellini. I'll read it. You linked the increased mortality in zone 0A with the difference in mechanical properties, but surely this region also has increased risk for tamponade or coronary occlusion, so accounting for the increased mortality. Any comment, Dr. Bellini?
Yeah, that's absolutely correct. What I presented what is the risk factors that are related to patients' anatomy, patients' mechanics, and I'm sure there is a hemodynamics aspect. There are surgical related risk factors that are outside my area of expertise, but both of them combined, I think that they would synergistically increase the risk, the worsening outcomes for the aortic root.
Thank you, Dr. Bellini. In the interest of time, I would again like to thank both of our speakers for wonderful presentations, and also thank the GenTAC Alliance for Basic and Translational Science for sponsoring this webinar, and also the Marfan Foundation for their support. This subgroup is chaired, the GenTAC Alliance subgroup is chaired by Dr. Diana Milovitz, who we also thank for her leadership. So with that, I'd like to thank everyone for joining us today and wish you all the very best. Take care. Bye now.